Major funding for these broadcasts has been provided by grants from New York Community Bank, AmTrust Title Insurance Company, Perfect Building Maintenance, M&T Bank, Customers Bank, Marks Paneth LLP, Ariel Property Advisors, Sterling National Bank, Capital One Bank, Collins Building Services, Meridian Capital Group. Additional support has been provided by grants from AVR Realty Company, Amerant Bank, Bank of America Merrill Lynch, B6 Real Estate Advisors, Briarwood Organization, Chase Commercial Term Lending, Chase Commercial Mortgage, Citizens Bank, CPEX Real Estate Services, Douglaston Development Levine Builders, Flushing Bank, Friedman LLP, Handler Properties LLC, Handler Real Estate, Hodges Ward Elliott INC, Investors Bank, James D. Kuhn Real Estate Center at Syracuse University, Kilroy Architectural Windows, New York's Window Company, Matone Group, New Banks, Newmark Knight Frank, Optimum Window Manufacturing Corp., People's United Bank, Rockefeller Group, Rosewood Realty Services, SJP Properties, Stonehenge NYC, TD Bank, Terra CRG, the Meringor Family Foundation, and these friends. Can you believe that doctors who are orthopedists and surgeons don't want to do surgery? It's a criminal offense. It's a shanda. But I have assembled, with the help of the infamous Rock Positano, this group of 3 healthcare professionals are going to talk about the new paradigm in healthcare, non-surgical orthopedics. My guest, as I said, my executive producer, my friend, the author of Dinner with DiMaggio and his brother over there, Rock Positano, who is the head of foot and ankle non-surgical at the Hospital for Special Surgery and the Joe DiMaggio Center, correct?
Yes, sir, Mike.
Okay. I cannot believe that this man is the chairman emeritus of the sports medicine, Brian Halpern, at the Hospital for Special Surgery. And last but not least, Doug Seckendorf, who is the head of the Manhattan Spine Center of the Hospital for Special Surgery. So you're surgeons. That's your business. You know, that's the lifeline. How do you how do you take care of patients without surgery?
Because we're not surgeons. We're actually non-operating docs who take care of 90% of all musculoskeletal problems, because 90% don't need an operation. 10% need an operation. So that 90% is encompassed by these other 2 great professionals.
So how do people find out about it? Okay, now I know firsthand because my wife, ironically, happened to see Rock, okay? And I knew Rock because of my involvement with the College of Podiatric Medicine, because of his involvement. But very few people know about all of these changes like PRP, stem cell. What are we doing today to omit doing surgery? And how are the 3 of you working in that involvement?
So this environment has been there forever in musculoskeletal care. We have just begun to refine it and realize that the approach, the comprehensive approach to musculoskeletal care, back pain, ankle foot pain, arthritis, shoulder pain, most of that does not need an operation. Most of that needs the appropriate diagnosis, the appropriate rehab, maybe some medications, maybe some injections. And then in the instance where it does need an operation, these professionals are so good, they will direct you to the best person for that specific operation for your specific problem.
Let's talk about PRPs, okay?
Go ahead.
Plasma. What is this? I mean, when do you recommend somebody going to see Brian or Doug with regard to PRP?
Well, that's a good question, Michael. I think what we try to do is try to use the more standard conventional ways of getting a person better. Different types of rehabilitation, whether it be traditional physical therapy, ultrasound, etc. And then when we find that a person's not doing well, we say, well, there is one other really, really effective alternative, provided that it's done by someone who has a tremendous amount of experience, integrity, and of course, knowledge. So of course, at that point, we'll refer them to Dr. Halpern, and we'll ask Brian to do a consultation to see, first of all, if the patient fits the model that he has pretty much worked out, where a person will do very, very well if they do a PRP versus someone who is not a good candidate.
Okay, we don't want to do inside baseball. We want to explain what this plasma program is and when it came around and how it's been being used today.
So it's been around for about 15 years. Originally it was done on racehorses and animals. The vets got it way ahead of our time, and they were getting racehorses back into the environment by injecting platelet-rich plasma. Basically what it is, take your blood, spin it down, concentrate your own platelets, inject them back into yourself, use your own body to reboot the healing process of whatever thing we're talking.
Is this a two-step procedure? Do you take the platelets first and then you inject them, or are they done at the same time?
Simultaneously, your blood doesn't leave the room, you don't leave the room. Takes less than an hour. You walk in, you walk out.
Now, what's the recovery period on the platelets?
So that's a great question, and that points to what Rock's talking about. People who are just injecting PRP who don't know the appropriate post-injection protocols. The recovery time is very different if I inject my tennis elbow than if I inject my arthritic knee. And that is designated by what the problem is and what we're treating and how to make them return to sport and return to athletics and return to their lifestyle as quickly as possible by utilizing their own system.
You know, we were talking in the green room about PRP and stem cell, that certain people are recommending it or doing the procedure who really don't have the appropriate training. When I did a Google search on Brian, I saw PRP. There have been articles written about your studies and work over there. But there are other people today, you know, in the same way as the Botox and the other scenario, people are doing shots and injections without the appropriate professional care.
You have people opening up shops all over the place that have no right or business doing PRP because they can make a profit on it. They don't know what they're doing. You want to look to, and it should be an MD or a DO. People that are not that really should not be doing it, but they are. You want to look to the people who have actually done some of the research so they can apply the research to each individual person, depending on the problem. But you're right. I mean, it's a Wild West out there with PRP now. It's not reimbursed, which is insane. Insurance should reimburse it. Everybody is jumping on the bandwagon, doing it for everything. I mean, PRP is used now for hair loss, PRP facials, PRP for this, PRP for that.
But it didn't help Rock.
Yeah, Rock looks great no matter what you do.
No. In your practice, Doug?
So it's a little bit harder in spine because we can't look at the spine and say that you have a torn tendon like you can in the elbow, identified on an MRI, and say we're going to inject platelets in this area, because the spine is much too schizophrenic, at least for right now, where we don't always know exactly.
So what type of procedures are you doing that, since you can't use the PRP or the stem cell?
So we're still stuck with trying it in areas where we believe that joints might be the culprit, in facet joints in the lumbar spine or in the neck, or just going back to epidural steroid injections and using cortisone to decrease inflammation. But the idea that we can take a disc herniation or a degenerative disc or an arthritic facet joint, introduce platelets and regenerate.
But you know, you bring up an interesting point. I remember a number of years ago, I think everybody has a dislocated L4, L5. That was something that I had. And I remember going to, this was a different hospital, and the anesthesiologist who did the epidural steroid. I couldn't walk before. Fortunately, he did it through a fluoroscopy. But many people consider taking shots more often than they should. What are you recommending in today's world about shots and other procedures? Okay, Rock?
Well, I know in the area at Hospital for Special Surgery, which, by the way, we are all privileged to be part of, an unbelievable institution that has provided orthopedic research, care, rheumatology for years and years. And in many respects, we're very fortunate to be part of that community. And when you're part of that community, you are also exposed to the best there is. And for instance, with our radiology division, we have a group that does ultrasound guided injections, which means in the old days, you know, you would say to a person, where does it hurt you? And they say, well, it hurts me here. And you would take a needle and you'd stick it in, and hopefully you hit the right spot. Well, the thing about ultrasound guided injections when it deals with a foot, for instance, because it's such a minute area. There's tendons, ligaments, muscles, bones, you name it. You know, I once told a patient, you know, giving an injection should not be like going to Disneyland. You know, you should know exactly where that injection is going. And the ultrasound guided technology, which has done wonders for people, not just foot and ankle, but also in knees, spines, backs, has done wonderful things for helping patients' outcomes to be really fantastic. So in that respect, you know, that type of technology really is one of the major advantages that, again, going back to what Brian says, which makes non-surgical musculoskeletal care so effective.
But the mainstay is not these injections. The mainstay
That's exactly right.
The mainstay is stuff that Doug does, putting his hands on the patient to make their back better, finding the right stretching, the right modalities in his hands. I mean, this guy works nonstop with his hands all day. You can't even move him at the end of the day. But his patients get better. Yeah. Most of them get better without these injections. Rock does the same thing looking at ankle foot, and myself as well. So the injections are down the line. They are very helpful when we use them.
How often should these injections? I was with a friend this week who plays a lot of tennis, and he said he was trying to get an injection up in Boston, and the doctors refuse to do it, maybe because there were too many times at the injections. I mean, it's the question of what are the procedures that were... Surgery is wonderful for certain conditions, okay? But it shouldn't be used all the time, and that's the specialty that the three of you don't do it. How do you make the determination of what type of work you should handle, okay? Somebody comes to you in the same manner that I mentioned my wife. She went to one physician, one orthopedist, who said you needed back spine surgery. It really related to her ankle. And you were able to give her different procedures, okay? Musculoskeletal approaches and the ultrasound, okay? You've never given her a shot.
You're asking the answer to what is really a very difficult riddle to solve often. And that's why I speak to Rock and Brian 5 times a day, 6 times a day. We're always communicating
because you're
with each
cultivating a team effort.
Correct.
Okay,
So,
is what you're doing, as opposed to one person sitting in a vacuum and making a determination.
and what also happens is that we've been socialized a little bit into thinking, I have pain here, where does the shot go? So a lot of times what we'll do is we'll try to work together. Some people are in so much pain and so much disability that they come to the office and the next stop is a cortisone injection to make them feel less pain so that they could at least do therapy. But a lot of times people are functional enough, and once we teach them that the idea is controlling something or avoiding things that are provocative.
The bottom line is patients are coming to the three of us because they are A, in pain, or B, can't function. And it is our job to figure out what is their pain generator. In their shoulder, it could be 10 million things, and if you're injecting the wrong thing or treating the wrong thing, they're not going to get better.
I know somebody who's been involved with trigger points for probably his entire career. Ironically, he was a psychiatrist who subsequently trained as a pain management. Mm-hmm. And he uses trigger point as his only approach, okay?
Well, that's the only tool in his box.
In his
he needs a bigger toolbox.
Right, he doesn't have a big toolbox.
That's like, we talk about this all the time. Things cause trigger points or tender points. They're not the problem. They're the result of the problem. So where you could say, oh, you have a tender point here, let me inject you with lidocaine and steroid, that's much similar to removing the light in your car that says low oil. And you say, okay, well, now we take the light bulb out and we don't have to worry about the low oil. So where Rock and Brian and I come into action there is we'll say, well, what's causing this deficiency? What's causing the problem? What are the right exercises? What's the right approach? You shouldn't need to be getting steroid and lidocaine injections repetitively in your life.
Don't they go bad? I mean, if you have too many of these steroid injections over a period of time?
Well, you should not have too much steroid, period, because it affects the entire system. Whether you're injecting in one area is affecting your entire system. So you have to be careful with that. But steroid is only one of the things you can inject. You can inject many different things.
Saline.
Once again, you need to understand why you're doing it.
I mean, there was a study with the PRP and the stem cells with the placebos, okay? The question is, many people thought that, oh, they're feeling better because they had a shot. In reality, it was a placebo. It wasn't any condition over there. So it's a psychological
The placebo effect is very real, absolutely real. It's not like you got nothing. It definitely can affect you. What the good studies are looking at the placebo effect versus the intervention. And the intervention is better than just the placebo effect.
So what type of intervention are we doing today in orthopedics? Foot and ankle, full body, and so on?
I think the important thing is the diagnostic capability and the interprofessional communication. Like, I think what the new paradigm is that we realize that all the body parts sort of talk to one another. Like, for instance, when Brian gets a person that has atypical knee pain, or Doug gets a patient who has atypical back pain, they'll say, well, let me take a look at the way the person stands and the way they walk, and let me look at their foot type. So I think the really important part, again, there's many, many parts to that question, Michael, but I think probably Brian and Doug could pick up on this, is that we realize that everything is connected. And for you to just look at someone's knee without looking at their hip or their foot or their back, for instance, is probably not a very good idea. So what we've been able to do is bring all of these areas together and show how they interconnect and how they work. And I really think that's what makes the paradigm that we do now at the Hospital for Special Surgery so different, because we look at the fact that everything is connected.
So what Rock is saying is we are treating the individual person, not their individual part.
Right.
We're in patient care. I mean, you're hurting, you're coming to us for help. We're trying to figure out what it is, but it's all encompassing. It's not just, all I'm going to do is look at your knee, and the only thing I take care of is your knee, and if it's not that, then I can't do anything.
What about arthritis?
Yeah, so that's a huge investment of money right now, because arthritis is osteoarthritis, which is the most common, which happens as we get older, has many components to it. Inflammation, obesity, malalignment. So we're learning more and more about these afflictions that we all are going to have as long as we coexist on this earth. And we want to be able to function better. We want to be able to isolate out various markers that are causing, that we may be able to follow this arthritis, what we can do to affect the outcome of the arthritis rather than just treating the pain. Maybe we can change the course of the arthritis. And this is in the osteoarthritis world. In the rheumatism world, there are already disease-modifying drugs that literally change the course of the rheumatologic disease, which we have not had. In the last 20 years we've had them. We haven't had them before that. So if you have a debilitating rheumatoid arthritis, God forbid, and you have your joints being wasted away, you take these drugs, they're called biologics. They have risk factors, but they can change the course of your life, and they can change the course of that disease. We're now trying to apply the same science to osteoarthritis, all the wear and tear stuff, our knee arthritis, our spine arthritis, our ankle foot arthritis. In Rock's case, inserts or orthotics can unload that joint and make it not wear as quickly, and that's appropriate. In Doug's case, he gets you doing the right posture, the right program, how you sit, how you stand, how you do your daily activity, and he works on the flexibility. That impacts it.
So here's the question. How many institutions are training the next generation to understand this? Okay, you go to school, you complete your residency, as they say, you're an orthopedic surgeon. A surgeon's job is to cut, okay? How do you train the next generation of young physicians who are going to get involved, in young podiatrists, into the specialty to learn what the three of you are doing, as opposed to the traditional medicine that we've had in the past?
It goes with the individual specialties. You're still going to train the orthopedic surgeons for the surgical piece. In the primary care sports medicine piece, which is I am, we start as primary care docs. We start as family docs, pediatricians, internists, ER docs, physiatrists, and then we get specialty training in sports and musculoskeletal care, and then we apply the entire continuum to the patient. So we already have the background of all the other things. We just apply the musculoskeletal piece.
Are there residency programs today in non-surgical?
There are fellowships in non-surgical sports medicine. I was the first fellow in this country to be a non-operative fellow called Primary Care Sports Medicine Fellowship in 1983. I don't want to date myself, but in 1983. Now there are approximately 200 fellowships for primary care sports medicine. And now in the country, we have a membership of primary care sports medicine doctors that surpasses 4,000 doctors.
You still need the philosophy of the individual surgeon, however, to elevate himself or herself to say, hold on a minute, and not operate just because an MRI looks a certain way or a symptom looks a certain way. So it takes a certain type of person. We're not training surgeons to not operate. We're training surgeons to operate, but the surgeons that we're fortunate enough to be affiliated with are working with us.
If I listen to the situation, HSS stands for Hospital for Special Surgery.
Correct.
Okay?
Right.
You're not non-surgical.
Right. So what happens is if you're lucky enough to come to a place like HSS where a lot of the surgeons are enlightened and they say, okay, your MRI looks like this, your symptoms look like that, but first, let's see if these disciplines can get you better, and if that doesn't work, come back and see me for surgery.
And HSS is adopting that model.
Yes.
I started as the only primary care sports medicine doc at HSS. We now have 15. Within 2 years, we're going to have 20 physicians just like me at HSS. So HSS realized, even though they're the Hospital for Special Surgery, and they are the best surgeons in the world in orthopedics.
Now, very interesting phenomena happened a couple of years ago. I ran into a guy, and I saw him. He was in a boot and crutches. And I said, what happened? He said, I just had a PRP. I said, where do you have it done? He said, I had it done in Kansas. I said, why do you have it done in Kansas? He said, the cost element was much less expensive since it's not covered by insurance. Are people doing cost-conscious approaches, traveling all over the country?
Some are, and you have some doctors that don't know what they're doing, are undercutting because they can bring in the volume. It's kind of, it's an insane environment right now. We're trying to establish criteria for what platelets we should inject, for what injuries we should inject with what platelets.
Right, so you're doing protocols, different
Yes.
type of protocols.
Exactly.
What's this new situation today with stem cell?
So stem cell isn't new. We've used stem cell for cancers, for multiple myeloma forever.
Right, for cancers,
Yes.
correct.
The stem cell application now is gone a little bit awry because, again, there's not a lot of research done in stem cells. There's not a lot of good clinical research, level 1 studies, which are double-blinded. People are just injecting stem cells because they can, and the concept is, if I inject this, something's going to happen. Well, we haven't really proven that yet. So the science, so that stem cell injections are ahead of the science. So we have to get the science catch up with the stem cell injections.
What about the pharmaceutical companies? How are they getting involved to make changes and advancements today?
Well, as a rule, we really don't align ourselves with
No, I'm not saying you're aligned in that, but I'm saying, you watch television and you see more pharmaceutical ads for every healthcare condition, including arthritis, including rheumatoid arthritis and other conditions. How are these medications, which are being advertised in the magazines and on television, having an effect when patients come to visit you? What should I do? I've seen this. This is the earth-shattering drug that's going to help save me.
Biologics.
Yeah. So you have to, the rheumatologists in the rheumatoid arthritic world, evaluate the value of these biologics we talked about, the ones that are coming out, the ones that have been out, the side effect profile, who is best fits this characterization to help them. The pharmaceutical companies are continuing to do the research in these various biologics. They are beginning to enter the world of osteoarthritis, and how do we affect osteoarthritis in a drug fashion or in a injection fashion other than the platelets or stem cells or things.
So here's the question. For the novice who doesn't know, how do they find people like you and other physicians who are practicing doing this new paradigm, non-surgical?
I think it's hard. We are, again, fortunate. We've known each other for a long time, so we use each other to have our patients have a certain type of experience, and you're just not going to be able to open up a book and see an advertisement, come see Rock Positano. So our patients come to us through referrals from other people we know, but I do say all day long with my patients, there are so many people who just don't know where to turn when they have a problem.
That's the biggest question. People don't know where to turn. They don't know. You bring up the point about orthotics. People think about it, or they go into the the Dwayne Reed or something, and they say, oh, this is an orthotic that I could use. It's
Right.
not an orthotic. It has to be built and customized. You know, the question is, people say, you know, oh, I have a sports injury, I should put heat on. No, you should put ice on. You know, people aren't aware of what's the right procedure to be done.
And they reach out to Dr. Google.
Yeah. They have a knee problem.
They
and-
reach out to Dr. Google or WebMD, and then they look at other things. And then, you know, when you put non-surgical, I'll get one of the clinics around the country, you know, in Kansas City, who's been an advertiser, who's paying for sponsored ads on the situation. So people don't really know where to go.
Well, the other good thing too is that we are also fortunate that we happen to be, you know, affiliated with a major medical center, New York Presbyterian Hospital, Cornell University, and many of the internists there, to their credits, will know right away where do we send someone who complains of knee pain or back
point.
pain or foot pain.
Right.
And in that respect, that's a very important resource because immediately the patient has a confidence.
Right, you have that, and then you have a great teaching hospital over there, highly regarded, so both of them help.
But I think the other thing too we were talking about is knowing how to identify which patients will do the best surgically. I think that's the thing.
Right.
You know, Doug and Brian and myself, we will try everything humanly possible to get someone well. But when it comes time, okay, we've done everything humanly possible. It's now time to go to the next step.
Right. And hopefully we don't go to the next step when they visit the three of you. And I'd like to thank my executive producer, Rock, Brian, and Doug, and I'll see you next week.
Thank you.
Thank you.